First of all, I want to welcome everybody. Good afternoon. My name is Peter Hoffman. I am a partner director with Garfunkel Wild in our compliance and white-collar defense group. I'm going to be joined this afternoon by my colleague Carmen and Jule as we present to you a webinar on health home audits and investigations are here. Are you ready? The presentation will be broken down into two halves. The first half will discuss the types of health home audits that we've seen to date, the ones that we think will occur in the future, and we'll address specific areas that health homes should be cognizant of that present risk areas to their operations. The second part of the program will help, hopefully, you to prepare for audits and investigations, describe how you can mitigate the risks to your business, and address what to do if you happen to discover a billing, documentation, or compliance issue, including the potential for having to refund overpayments. We're also going to attempt to leave a little bit of time at the end for questions. We have quite a bit of material to cover today, and if we run over a bit, we hope that you will stay with us. So with that, let me turn over the presentation to Carmen and Jule, who will discuss the first half issues, and let's get started. We are socially distanced, so I'm going to put my mask back on as we switch places and invite Carmen to come over and begin the presentation. Thank you very much.
Good morning, everyone. My name is Carmen Jule. Thank you for joining us today. So before I get started, just want to, for everyone in the audience, just want to give the general definition of what a health home is. Right? A health home is generally a group of healthcare and different service providers that are collaborating to ensure that certain Medicaid beneficiaries receive necessary care and services. Now, in this presentation, we will be focusing on health homes generally. However, it is also a helpful and useful presentation for providers that participate in health homes, regardless of what specific service or supports they provide to the health home enrollees. I want to specify that we will be focusing primarily on New York health homes, but we will also discuss health homes in New Jersey and Connecticut to the extent that there are significant differences or similarities. And just to further clarify, health home models, service models in New Jersey and Connecticut are called behavioral health homes. For purposes of this program, we will be referring to them as health homes. And I apologize, those were the objectives that Peter discussed previously. So who audits health home services? Well, audits can be conducted by federal and different state agencies. At the federal level, audits may be conducted by the Department of Health and Human Services Office of Inspector General, which may audit specific states in their provision of health home services and programs. Audits or reviews may also be conducted by the Department of Justice or U.S. Attorney's offices. In New York, you would have audits potentially conducted by the Department of Health or the Office of the Medicaid Inspector General. In New Jersey, similarly, the Department of Human Services, Division of Mental Health and Addiction Services, or the Office of the State Controller Medicaid Fraud Division. In Connecticut, the Department of Social Services and the Department of Mental Health and Addiction Services could potentially audit or conduct investigations of health home services. Additionally, states that have health home services may also be, audits may be initiated by the Attorney General Medicaid Fraud Control Units of the respective states. And it is possible also that health plans, such as managed care organizations or managed long-term care plans, may also conduct audits. Now, at the federal level, as of 2017, CMS has approved Medicaid state amendment Medicaid state plan amendments for 21 states and the District of Columbia for health home programs. The Office of Inspector General has added health homes to its work plan for the past year. OIG expects to complete an ongoing review of Medicaid health home services for beneficiaries with chronic conditions this year and going into next year. To date, 3 different reports for 3 different states have been completed, and the first report was for payments made to New York. We can expect to see more reports completed next year. In its review of New York Health Home Services, which was completed in July of 2019, the OIG reviewed approximately $850 million in payments made by New York State to health home providers for services provided during a 4-year period. The OIG reviewed 100 samples and found that for 22 of them, the state agency improperly claimed federal reimbursement for payments that were made to health home providers. The improper claims were on the basis that the documentation did not comply with applicable federal or state requirements. The OIG estimated that New York State improperly claimed approximately $65 million in federal Medicaid monies for payments made to health home providers. The OIG found that New York State didn't adequately monitor health home providers' compliance with federal and state requirements regarding the provision of health home services and the documentation and billing of those services. The deficiencies included that services were not provided according to comprehensive individualized plans of care. Health homes did not ensure that beneficiaries participated in the development or execution of their individual plans of care. The health home's failure to maintain documentation to support the services that were billed, or incorrect billing and billing for services that weren't in fact provided. And the OIG determined that New York as a state claimed reimbursement for services that duplicated similar services provided to the same beneficiaries under different Medicaid-funded programs. The OIG recommended that New York State refund $65.5 million to the federal government. It also recommended that the state improve its monitoring of health home programs to ensure that the providers complied with applicable federal and state requirements. New York did respond to the OIG's report. The state did not indicate concurrence or non-concurrence with the OIG's recommendations. It did, however, indicate that it had already taken steps to ensure that health home providers were in compliance with applicable requirements. It was already investigating and reviewing certain of the unallowable payments that the OIG identified, and it otherwise disagreed with the OIG's statistical sampling methodology. In addition to its review of New York State, the OIG completed 2 other reviews in April of this year. In one review, the OIG determined that Iowa inadequately monitored its Medicaid health home providers, which resulted in more than $37 million improperly claimed in federal Medicaid reimbursement. The bulk of the deficiencies in that report related to documentation issues, such as the failure to document core services, outreach services, member diagnoses, and member enrollment, the failure to maintain documentation to support higher payments for integrated health home services, the failure to ensure members had full Medicaid benefits, and otherwise poor monitoring of the health home program by the state for the health home program's compliance with the applicable federal and state requirements. In another report, the OIG identified that the state of North Carolina received more than $30 million in excess federal funds related to improperly claimed health home expenditures. In that report, the OIG determined that North Carolina improperly claimed more than $124 million in primary care case management expenditures, which should have been reimbursed at the regular federal medical assistance percentage, but were reimbursed at an enhanced rate for health home services. Of the payments the OIG reviewed, it determined that none met all the requirements for payment as health home services. and that the state miscategorized them as health home services. The OIG determined that the state claimed the primary care case management expenditures as health home expenditures because it did not take certain steps to ensure implementation of the health home option and did not implement internal controls to ensure compliance with health home services and the related federal reimbursement for those services. Now, in addition to federal audits of health home services, states have also increased their audit activity, and New York is a good example of this. The New York Office of Medicaid Inspector General, OMIG, has started and will continue to audit health home programs. In the few most recent reports issued in September and October of this year, the OMIG has reviewed instances where health home services were billed on the same month for the same beneficiary as other care management services, particularly Office of People with Developmental Disabilities, Medicaid Services Coordination Services. They're in the various audits. They've also identified billing of duplicative services and have determined various overpayment amounts in each final audit report, which is inclusive of accrued interest. So based on the increase in audit activity by the federal and state agencies, it is important for health home programs to analyze their risk areas and compliance risk areas for themselves and the providers that participate. Health homes generally need to monitor and address documentation that does not support the provision of or the billing for health home services. These risk areas can occur in the broad categories of beneficiary eligibility, the determination of the appropriateness of health home services for beneficiaries, beneficiary consent for participation in the health home, and the provision of health home core services. Now, requirements in the states that have health home programs may vary, but these are the general categories of risk areas and that are relatively similar. And when I say appropriateness for health home services, I mean any other criteria besides the eligibility of an individual based on having a certain condition or having Medicaid status. And that determination of whether health home service is appropriate does vary by state. And again, while we will be focusing primarily on New York, we will discuss any notable New Jersey or Connecticut aspects. So the first threshold risk area for a health home is the eligibility of the beneficiary. In New York, health home services are available for Medicaid-enrolled adults or children, and it varies depending on whether the beneficiary is an adult or a child. For adults, the adult must have either 2 chronic conditions or a single qualifying condition. The Department of Health has a very specific list of potential chronic conditions that may qualify, and for single qualifying conditions, this can include HIV or AIDS, a serious mental illness for adults, or for children, a serious emotional disturbance or complex trauma. Depending on the beneficiary, the health home does need to have a documentation to support the determination that the individual is eligible, such as medical records, assessments, and documentation showing the diagnoses. Now, in New Jersey, behavioral health home service models are only available in select counties, and eligibility for participation in the behavioral health home is for Medicaid-eligible adults and is based on the adult having 1 or more qualifying serious mental illness. In Connecticut, the eligibility criteria include that the individual is enrolled in Medicaid and has a qualifying diagnosis of 1 serious and persistent mental illness. Additionally, the Medicaid program has determined that for this individual, it has paid in excess of $10,000 per year. In addition to the eligibility criteria, there is generally a requirement that health home services be appropriate for the beneficiary. This generally means that the individual has been assessed and found to have significant behavioral, medical, or social risk factors that would require the intensive level of care management services that health homes provide. In New York, there is recent guidance by the Department of Health that provides numerous examples of the type of documentation that would support the determination of appropriateness of health home services. Similarly, in New Jersey, in addition to being eligible, adults must have a serious mental illness and also be at risk of increased utilization of medical and behavioral health care services. Some considerations that may be applicable or may be taken into account when determining if health home services are appropriate include the possible risk for adverse events such as death, disability, an inpatient or nursing home admission, mandated preventative services, or out-of-home placement. The lack of or inadequate social, family, or housing supports, or serious disruptions in family relationships, as well as needs, benefits, and nutritional insufficiency of the beneficiary. Lack of inadequate connectivity to the healthcare system. A beneficiary's non-adherence to treatment or to medications, or difficulty managing their medications. Recent release from incarceration, detention, psychiatric hospitalization, or other placements or justice referrals. Deficits in activities of daily living, any cognition or learning issues, or if the beneficiary is currently eligible or currently enrolled in another health home. And once it has been determined that an individual is eligible for health home services and that health home services are appropriate, you still need beneficiary or member consent to enroll in the health home. In New York, there are various consent forms for different circumstances, depending on whether the individual is an adult or a child, or if the individual is consenting to participate, withdrawing their consent, or opting out of the health home. Each consent form has very required boxes or fields and requires signature by various individuals participating in the care of the beneficiary, as well as regular review of consent forms. And in New York, in some cases, the lack of consent forms or incomplete consent forms could impact the ability of the health home to receive payment for the health home services provided. Health homes must also be cognizant of the risk areas that are associated with health home core services. Generally, health homes provide the following core services: comprehensive care management, which may include outreach and engagement activities, care coordination and health promotion, comprehensive transitional care, enrollee and family support, and referral to community and social support services. And there are risk areas associated with each of these core services. For example, with respect to comprehensive care management, one risk area is the billing for unacceptable outreach or engagement activities, depending on the applicable rules and guidance that are in place for a specific period of time. So for example, in New York, effective July 1st of this year, there is no longer reimbursement for outreach and engagement activities. However, for prior dates that are still maybe subject to audit, the billing guidance varies depending on specific time periods. And this could impact the frequency, based on the frequency of outreach or engagement activities, or which type of outreach and engagement activities are acceptable or not acceptable based on applicable guidance. Another risk area is the timeliness of the completion of comprehensive assessments and development of plans of care and approvals by a respective managed care organization or payer of the same. For example, for a plan of care, there is required minimum elements that must be present, which vary depending on whether the beneficiary is an adult or a child or otherwise special population. Minimum elements may include the goals and preferences of the beneficiary, the strength of the beneficiary or the functional needs, community supports in place or provider support, barriers to accomplishing the beneficiary's goals, and participation by key providers, to name a few. The timelines for completion of the initial comprehensive assessment, there are timelines for the completion of the comprehensive assessments, the initial ones, as well as reevaluation and reassessment of the plan of care. There are also timelines regarding regular reassessments and more frequent reassessments depending on whether there's been a change in the beneficiary's status or condition. With respect to care coordination and health promotion, risk areas include documentation that does not demonstrate coordination with various service providers and sharing of information between those providers. So, for example, crisis intervention. Failure to conduct case reviews with interdisciplinary team to assess the member or beneficiary's status and its service needs. Failure to monitor or support or accompany the member to schedule medical appointments, which as may be applicable, and ensuring required crisis intervention and any revisions to the plan of care or goals accordingly. With respect to the core service of comprehensive transitional care, risk areas include failure to follow up with hospitals or emergency departments upon notification that the member has been admitted to the hospital or emergency department, and similarly, failure to follow up with discharge from a hospital or emergency department or a rehabilitation or residential facility. Failure to facilitate discharge planning from the hospital or an emergency room or nursing home to a safe transition and discharge where the beneficiary's care needs will be in place. Failure to notify or consult with the treating clinicians or schedule follow-up appointments or assist with medication reconciliation. Failure to link the client with community supports to assure that needed services are provided during the transition. And failure to follow up post-discharge with the member or the member's family to assist in the member meeting the plan of care needs and goals. With respect to member and family supports, risk areas include the failure to develop, review, or revise the member's plan of care with the member or the family member, and ensure that it reflects the member's preferences, education, and support for self-management. Failure to consult with family members and the member or caretaker on advanced directives and to educate on the rights which may be needed. Failure to meet with the member or family, or failure to invite other providers to facilitate the interpretation services that may be required. Failure to refer the member or the family to peer support groups or social services or entitlement programs as may be needed for the member. Or failure to collaborate or coordinate with community-based providers to support the effective utilization of services based on the member's needs. With respect to the core service of referrals to community and social support services, risk areas include the failure to identify resources and linking the member with community supports as may be needed, and the failure to collaborate or coordinate with community-based providers to support the utilization of those services. Now again, these are general risk areas for health homes. The types of risk areas I've discussed are not the only potential risk areas, but generally, the health home care management record must include records of determination of the beneficiary's eligibility and evaluations, completed and signed consent forms, initial comprehensive assessments and reassessments and plans of care and revisions of the same, applicable progress notes, and any referrals made between different providers or to different providers. And in addition to these general risk areas, there may be more specific risk areas related to the ongoing COVID-19 public health emergency. For example, in New York, temporary waivers have been issued specifically for health homes. This includes the waiver of face-to-face requirements for assessments, plans of care, unless otherwise medically necessary. So now members may consent verbally, or they may, if they don't have access to telecommunications platforms, Electronic signatures may be used under certain circumstances, and teleconferences or secure communication telehealth capabilities may be used to obtain consent. Additionally, there has been a temporary waivers regarding the timeframes to complete the comprehensive assessments and plans of care. The timeframes have been extended from 60 days to 120 days. There's been a temporary listing of requirements regarding family team, care team, or multidisciplinary team meetings. And the timeframes for the reviews of the plans of care have been suspended or updated, and otherwise to ensure that the plan of care is up to date despite difficulties during this public health emergency. The important thing to note about these waivers is that regardless of the fact these waivers are in effect, there is still a need for appropriate and clear documentation about the method of consent, the evidence of activities taken by the providers to complete assessments, to complete and review the plan of care or other required documents. And again, these are temporary waivers. So providers and health homes must be tracking DOH guidance and updates regularly and must be ready to resume the prior procedures and adhere to prior timelines or requirements when these waivers end. And in New Jersey and Connecticut, there have been some temporary changes related to COVID-19 as well that may impact the way health home services are provided to beneficiaries. So for example, in New Jersey, the Department of Human Services Division of Mental Health and Addiction Services has issued guidance regarding the provision of telemedicine and telehealth and telecommunication support services for behavioral health provider agencies to address services during COVID-19. Similarly, in Connecticut, there have been executive orders which allow for the flexibility of Medicaid providers to perform telehealth via audio-only methods for new patients and provision of telehealth through additional methods. Again, the same precautions apply. These are temporary waivers or temporary changes, and providers must track applicable rules and regulations and guidance to make sure that they are otherwise in compliance. So, in addition to all these risk areas, there is an inherent tension for health homes and health home providers between the complying with applicable rules, regulations, and guidance, and timely submission of claims and payment for services. An example of this in New York, for example, health homes must submit claims to managed care organizations or managed long-term care plans within 120 days after a date of service, unless the applicable contract with the payer is negotiated otherwise. And the health homes have to comply with the claim submission procedures for each payer. Once the health home submits the claim to the payer, it has a time frame where it has to then remit payment to the provider, the subcontractor provider, such as the care management agency. So there is this inherent tension between timely submission and timely payment and adherence not just to the health home regulations and rules and guidance for the operations, but also compliance with federal and state laws to prevent or ameliorate fraud, waste, and abuse, which includes federal and state false claims laws, anti-kickback statutes, and other laws. And with that, I invite Peter to join us and to discuss that further.
Thank you, Carmen. That was a very thorough explanation for a lot of the risk areas that health homes and their downstream providers can face. And I think it underscores why it's important to know what the rules are. And what we're going to turn to now is how they can impact the health home, the downstream providers, when those rules are not followed. And I thought one way to begin is a refresher on some of the fraud and abuse laws that could apply depending on the circumstances involved. So we're going to talk about an overview of some of the key fraud and abuse laws, and then we'll move into ways to mitigate risks for you as a health home agency or you as a participant, a network provider in the health home agency. So let's start with some of the laws that apply. One of the main ones that I'm relatively sure that most participants on this webinar are aware of is the False Claims Act, Federal False Claims Act, known as in the industry as the weapon of choice. It prohibits a number of things, including knowingly presenting or causing to be presented a false or fraudulent claim for payment or approval. Note, it doesn't need to be a fraudulent claim. It can be a false claim, which is a much broader term. The law also prohibits making, using, or causing to be made a false record or statement that's material to a false claim, and that goes to what's in your notes primarily, what's in the documentation. And this is a big one, knowingly concealing or avoiding an obligation that you as an agency have to pay or transmit money back to the government. And an obligation specifically includes a duty that arises from the retention of a known overpayment. And we'll talk about what that means in a minute. The FCA, as you're probably aware, has certain provisions called key TAM provisions. What those allow essentially is a private party to bring an action on behalf of the United States government. And it's really an incentivization provision to have whistleblowers come forward, and the incentive comes in the form of if the matter is ultimately successful, either in court or via settlement, the relator who brought it forward, provided that certain conditions are met, is going to share in the proceeds of the recovery, substantial percentages, 25, 30% in some cases. The penalties for violating the False Claims Act are really substantial. So while the key TAM relators have an incentive to report, the parties that are subject to an FCA action have an incentive to resolve it, because recently they have upped the per claim penalties to nearly $12,000 on the minimum side and over $23,000 on the upside. And those are per claim penalties. So you can imagine, you know, you're usually not talking in a compliance situation about one claim. You're talking about multiple, maybe tens, maybe hundreds, maybe thousands. And if you start multiplying those numbers, they become astronomical. And of course, treble damages, and what that means in lay terms is if the damages are $10,000, treble that amount is 3 times, $30,000. So when you start adding treble damages and the claim per claim based penalty of the amounts referenced, the potential risk goes through the roof. The state laws have very analogous False Claims Act. That goes for New York, that goes for New Jersey, that goes for Connecticut. They're similar to the FCA. We won't spend too much time on them. They do apply to false claims and false records that are submitted to officers or agents of a state or local government. They do have treble damages like its false claims federal counterpart. They do have per claim penalties, substantial, and they do have key TAM related provisions as well. Aside from the civil laws, the monetary-based laws, there are criminal laws. One, for instance, is a federal healthcare fraud statute that basically says that if you're acting with intent to defraud a benefit program, and that could be a public or private program, an HMO, Medicare, Medicaid, if you are knowingly and willfully executing a scheme or artifice to get money by false pretenses that is related to the delivery of healthcare services or supplies or items, you can be guilty of this statute, a violation of the statute. And the penalties are different. This isn't just a monetary issue, it's a criminal issue. So you're subject, if this law is implicated, to fines, to actual jail time, significant jail time, up to 10 years, and it could be even more if the conduct results in serious bodily injury, up to 20 years, and God forbid, somebody dies as a result of the conduct, and you can actually go to jail for life. So the consequences, I think it's clear, are quite severe. In your relationships with your downstream providers as a health home, or those who might be on the call who are downstream providers, CMAs, you don't want to get patients to sign up via kickbacks. That's essentially offering something, a reward, remuneration in return for getting the referrals. That too is a criminal statute, very severe penalties, both under criminal law, civil law, which is monetary based, and administrative law, where things like exclusion from Medicare and Medicaid can result. And then there's just a panoply of other laws, state laws on anti-kickback, Medicaid rules, insurance laws, criminal laws. So the takeaway from that is there's a whole heck of a lot in Medicare and Medicaid in general, but in health home in particular, that you have to be aware of. And if you're not following the rules, particularly intentionally or knowingly, and even a bit recklessly, there's substantial exposure that is possible. So what do you do? What do you do? Carmen's gone through a good number of risk areas that you may see in your daily practice. How do you be prepared for an audit that's coming? We've seen OIG audits. We've been participants with those audits. We have seen now OMIG doing their desk audits, so they're picking up. And one thing I want to note, Carmen laid out at the beginning of the presentation that there have been several OIG audits, including in New York State, and there are more to come. Those audits are technically of the state's claim, in that case New York's claim, to the federal government for their share of the federal financial participation in the Medicaid program. It's not exactly 50-50, but the state does get reimbursed for the expenditures, the payments it makes to health home providers. What happens next is that the state, in this case OMIG, turns around, if they have to pay money to the feds, and do what you would expect them to do, which is go to the providers and say, we paid this, it's your fault, although they don't quite say it that way, so now you pay us, because they don't want to be on the hook. So how do you be proactive? Lots of different ways, some of them common sense, some of them things you just may not have spoken of. One, take a look at your policies on a regular basis, semi-annually, minimum annually. See if they're up to date. The rules, I know, particularly in New York, are constantly being tweaked and changed. The health home program is still not that old. I think it was issued with wonderful intentions, really to try to lower costs in the Medicaid program. But the rules, as with many programs at their inception, had some gaps in them. And that leads to questions, and as those gaps are being identified, there are new policies and tightening. It's really incumbent upon both the health homes and their downstream providers, the CMAs, to be aware of what's going on. You want to actively monitor updates. You want to conduct continuous staff and contractor in-services and education programs. And one of the big things we found in our experience is there should be a point person. So, for instance, if the health home as the lead has multiple CMAs under contract, who is in charge of communicating with the downstream CMAs to make sure things are being done, both education by the health home and education at the CMA level. And one of the things that we found to be particularly important is to set up liaisons. Someone at the health home level should be in a designated point person to communicate with the downstream providers and make sure these types of issues are being discussed. One way to do that is a compliance program. Compliance program will touch upon the elements in New York, but a compliance officer is often a good person to serve in that liaison capacity. Compliance programs, which I just mentioned, are also a way to mitigate your risks. Federally, there have been statements that if you're enrolled in Medicare or Medicaid or CHIP, you have to have a compliance program with core elements. There really hasn't been regulations issued on this. There is a webinar that we're pointing out on the screen that talks about the core elements, but they're generally the same as what you would expect to see under New York law. And in New York law, unlike so far where we are with the feds, there is very specific rules. There are rules as to who compliance programs apply to. They're known as required providers. Those are listed here on your screen. Article 28, for instance, hospitals. Article 36 of the public health law. Mental hygiene law, those who are governed by Articles 36 or 31. MCOs and managed long-term care plans. And this really has relevance to the health home world. Providers, participants, affiliates who provide care services and supplies under Medicaid, when the business they generate is a substantial portion of their operations. What is substantial portion? This is a very wordy statute, so I apologize for the density of it, but basically it breaks down into a couple of things. Who and how much. The who is you are considered to be doing a substantial portion of your business if you claim or order services and supplies from Medicaid of $500,000 in any 12-month period. That's number one. Number two, if you receive or have received $500,000 in any consecutive 12-month period, directly or indirectly from the Medicaid program, and that sweeps in your managed care Medicaid providers, and a little less so probably likely to those on this call, those who claim or submit claims. So billing companies. Again, the threshold being $500,000 in the consecutive 12-month period. So most health home providers, particularly in New York, are going to fall into that category. And I can't emphasize enough, proactive compliance activities are going to require you to have a compliance program. And compliance programs in New York are mandatory. We've been working on those for many, many years. They were recently amended, more tweaked than amended, but there are 7 required elements. The first slide is a bit lengthy. I won't go through it in detail. You'll have it, or we can get it to you after the presentation. But essentially what this says is written policies and procedures that touch on a number of things, that you're committed to complying with applicable federal and state standards, that you lay out what your expectations are in a standard of conduct, sometimes known as code of conduct, that you actually implement what you're doing. So having paper is not just enough. They want you to provide guidance to your employees and others on how they deal with potential compliance issues, how they're addressed, how they're reported, how they're resolved, and you need to have a policy in place under the state law that touches on particular state laws that goes to non-intimidation, non-retaliation for those who good faith participate in compliance programs. So, you know, oftentimes a client will call and say, well, they have this, they're a bad actor, we're going to fire them. May or may not be justified, but certainly is an issue to explore because it raises whether you are retaliating somebody from participating in the compliance program. And I'm sure most of you have heard of the federal DRA, the Deficit Reduction Act, that requires, if you meet a certain dollar threshold, to disseminate information as part of your compliance program on education on false claims, whistleblower laws, really telling people the protections that they may have. Other requirements, you need a compliance officer and a compliance committee. They have to be accountable to your CEO or senior management. You need training and education, and that's got to be widespread. It's got to be for the compliance officer, for your employees, for your CEOs, for your senior management, for the governing body members. It has to occur at least annually and on new appointments as well. You need effective lines of communication. There has to be confidentiality. That gives the aura and hopefully the reality of I am not going to be treated as an outlier or not a team player if I am reporting issues up the chain of command, including the downstream providers who are participating in your compliance plan. You also have to have an anonymous and confidential way to report. Those two terms are defined separately. So you want to be careful and inquire about, is your method anonymous? Is it confidential? Do you need one method or two separate methods to allow appropriate reporting? Disciplinary standards have to be part of it. You need systems in place to monitor. That means you should be doing internal and external audits as appropriate to look for, are we in compliance? Is our compliance program operating effectively? And finally, you need a system in place to respond. How are you going to respond? How are you going to investigate? And what are you going to do when you find a problem? These are the areas that New York says to cover, that have to be covered. Billings, that's not a surprise. Payments, not a surprise. Medical necessity and quality of care. In the old days, compliance wasn't really concerned with quality of care. There was a QA function, particularly at institutional providers like hospitals, a QA, a QI committee. You need to touch on governance, things like conflicts of interest, mandatory reporting, which we'll touch on in a minute, credentialing, and anything else that's relevant to what you do. And those are the areas you want to make sure are covered. Now, compliance is, can I have that please? Compliance is very important. There were changes made in April in the height of the initial wave of the pandemic that kind of snuck through under the radar, that incorporated, this has always been true, but it incorporated specifically into the law that if you are required to have a compliance program and you don't, it's a condition of payment for Medicaid, for Medicaid services. And what that means is if you need a compliance program and you don't have it, Any claims that you're submitting to Medicaid should not be paid and are subject to recoupment. They also added penalties. This is relatively new. If you don't have a required compliance program, you can be subject to $5,000 a month in penalties for up to a year. That's for the first violation. If you've had a violation in the prior 5 years, those penalties double to $10,000 a month. So that's all in the law, the compliance. Those are things that you should be aware of and will help you mitigate risks. Let's turn for a few minutes to discovering compliance issues. I'm going to try to speed up a little bit because time is short. You'll want to do regular self-audit. Do not be afraid to look for and discover compliance issues and deal with them. Putting your head in the sand often results in worse results than finding issues and dealing with them head on. Downstream CNAs, they should be doing the same, and I referenced earlier having a liaison. The CMAs should report to that liaison at the lead and work cooperatively. In New York, for instance, the bills are submitted in the lead's name, and ultimately they're on the hook, even though many of the services, if not all of the services, are conducted at the downstream CMA level. You should have a compliance work plan for the coming year, and you want to have systems to respond if issues come up. It shouldn't be ad hoc. So you do a self-audit, and you should not be afraid to do self-audits. Part of a good compliance program is finding issues before someone else, such as the government, finds them. How do you do that? Pick an area. It could be anything, something a government payer in a work plan or in an audit has identified. It could be a member complaint. It could be something that you say, you know what, this doesn't seem right, or we have a new CMA and we want to look at it. When you're auditing, make sure to use the applicable rules that were in place at the time of the service. These rules change often. If you're looking at 2015 and 16 and the rule changed in 2019, don't be applying the 2019 rules. Time frame. How long should my self-audits be? Well, there should be a rationale. Sometimes a new policy was put in place, and it was only put in place 2 years ago. You may want to limit your initial review to that 2-year period. You may have gotten a new EHR system or changed one, and maybe there's some glitches in it. So that demarcation point could be relevant. And any others. Those are not meant to be all-inclusive. Sample size, we typically recommend start early, start slow, start small. If you need to expand it because you continue to have findings, you can do so. And not to have a bit of a sales pitch, although it's somewhat obligatory in this type of thing, you may, depending on the circumstances, want to reach out to counsel. If you need experts, you might want to consider having those experts retained under a COVAL agreement. Correcting issues. What do? Again, some of this is kind of common sense. First thing, cut off any financial liability going forward. Fix the problem. How do you do that? New policies, revised policies, in-services for the health home or the CMA staff, and follow-up. This is one thing we often see. Clients put fixes in place and then do not follow up to make sure that they are being followed. And discipline. In a worst case, you want to warn your providers, educate them, and perhaps you may need to terminate them. And now refunding. People's one of the least favorite topics. You may come across a situation which requires you to report, return, and explain. I'm going to try to go through this fast. Many of you may be aware of this already. There's a couple of different laws. Federal law under the ACA, you have 60 days to report, return, and explain identified overpayments. That's Medicare or Medicaid funds that you're not entitled to. That's an overpayment. You have to return them to the appropriate party. Could be DHS, the state, contractor. You have to give an explanation in writing. And the general look-back period is 6 years, although if there's a rationale to do less, for instance, we think this problem arose when we hired Johnny Smith to be the new supervisor. That may be a rational point to do less than 6 years, but that's going to be a fact-specific determination. Identified means under Medicare Part A and Part B that the person has or should have, using reasonable diligence, determined that there was an overpayment and quantify it. That's when the 60-day period kicks in to report, return, and explain. So keep track. When did you first learn of something, and are you acting with diligence? The 60-day period can also start if you have credible information that there was an overpayment and you bury your head in the sand. So do not bury your head in the sand. These are difficult issues, but the best approach is to deal with them head on. And reasonable diligence means both being proactive and responding in a timely manner. And under the federal side, they generally say 6 months from the time you get information, credible information, unless there's extraordinary circumstances. The pandemic, in our view, does qualify, so if things have been slowed down this year to a degree, that might be helpful. In New York, we just had amendments in April of this year to essentially incorporate the same type of requirements that exist under the federal ACA. 60 days, report, return, and explain, identified overpayments. And the last area I want to touch on is we do have self-disclosure, both on the federal side in New York. Many health home payments are Medicaid funded, and so New York disclosure has a process. And clients often say, well, what should we report? And here on this slide are certain examples of things to be reported. Billing errors, fraud, excluded providers. You're supposed to be checking regularly if you have any excluded providers. Documentation errors, overpayments that result from changing billing systems, things that really are encountered day to day. Those are the types of things that you should be reporting. The law also added eligibility. You can't be under audit for the same issue. You can't say, I got an audit, okay, I'm going to self-disclose. You have to be disclosing something that OMIG's not aware of. You have to follow the deadlines. And this is tricky because the deadlines, the 60 days, and what it means to identify an overpayment are tight and very hard to follow. But this is now part of the law in New York. And you can't be subject to a criminal investigation. So they don't want you to try to, the bottom line on that is they don't want to try to have you circumvent either an audit or an investigation that's ongoing or a criminal investigation by saying, okay, we self-disclose that after the fact. The way to do it, there are forms. You can do a letter. OMIG is going to review what you've submitted and say it meets the qualifications. They'll reach out to you if you have, or your representative, oftentimes lawyers like us. If you have discrepancies, they'll send a final letter, and then you have to remit payment on a relatively short time period. The new statute talks about 15 days. Historically, it's been 20 days. If you have financial difficulties, you can seek a repayment agreement. And the last point I want to point out is the managed care organizations and MLTCs, you have a contract with. And those contracts typically require separate reporting to them of suspected fraud, waste, or abuse, or crimes. Those processes vary, and in New York, one good thing is that you can include overpayments to Medicaid MCOs, MLTCs, in your self-disclosure to OMIG, which previously, historically, had been for fee-for-service. But keep in mind, health homes may still have independent reporting obligations under their contracts to MLTC. So these are ways that you can mitigate risk. You have, we've identified a number of risks, as Carmen did for you. We've identified ways we hope you can deal with it. We're running a little bit late. I don't know if there are any questions. Can we see any questions up on the board or nothing? Okay. So there are no questions, but but we are happy to communicate with anybody who may want to talk to us offline. We often find that clients or potential clients are more comfortable not having questions raised in this setting, but would prefer to speak to us privately. We welcome that. Our contact information is towards the end of the slides and is currently up on your screen. We certainly hope this has been a helpful presentation, and we look forward to hearing from you, working with you, and helping to mitigate any risks or concerns that you may have. So thank you very much for your patience. A lot of information today. We hope and trust that you find it helpful, and we certainly look forward to hearing from you in the near future. So with that said, thank you very much. Stay safe and have a good afternoon.